Morning, everybody. Dr. Gillard here. It's week 9. It's Tuesday. It's time for a CVPP lecture. Off we go. Now, last week we stopped at the P wave. So let's just remember what the P wave is. That's the P wave right there. And that represents the wave of depolarization spreading over both atria. What is this? That's the PR segment. That represents the electrical neutrality of the current. There's no current here, right? This is the isoelectric line. It's flat. So this is the current has gotten out of the atria, or it's most of the current, all of the current is in the AV node, and it's being held up there, right? So that's the P wave. All right, so it represents, as I just said, the depolarization of the right and left atria. It's normally tiny, right, compared to the QRS complex, because the ventricles have many more miles of wiring that have to go through. The more wiring you have, the bigger the wall of the heart, the more voltage will register. You have to push more voltage through. And we talked about the Weger's diagram last time, where the contraction, the physical contraction of the atria, doesn't happen until about right here. Right? So that first part is silent. No muscle is moving or twitching yet. The wave is just starting to spread. So there's a little delay. And we talked about the Weger's diagram. I'm not going to go over this again, but make sure you know there's the P wave right in the middle of it all. And you can see that atrial systole actually occurs right here in the middle of the P wave. And that's going to create an S4 heart sound if you have a pathological heart condition, like a very stiff hypertrophic left ventricle. So what are the dimensions of the P wave? Well, we have a nice 2.5 little box rule that works quite nicely. So the P wave should never be longer than 2.5 millimeters, or little boxes, right? There's a P wave that is only 2 boxes. Remember, each box is 0.04 seconds. So that would be 0.08 seconds. But the maximum duration should never be more than 2.5 little boxes. 2.5 times 0.04 is 0.10 seconds, 0.10 seconds. So the maximum duration, and that's the length of a P wave, should be no more than 0.10 seconds. The height can also be, never be more than 2.5 little boxes high. And that's really easy, right? 2.5 little boxes is the same as 2.5 millivolts. So hence, we get the 2.5 millimeter little box rule. Okay, the axis. We're not going to talk much about the axis, but there is an axis. We talked a whole bunch last time about the mean electrical axis of the ventricles, which heads where? Toward the southeast. So the mean electrical axis of the atria also heads to the southeast, but it actually heads a little bit more to the east. So east-southeast is where the mean electrical axis of the atria travel. All right, specifically between 15 and 45 degrees. A little more east than the ventricular mean electrical axis. What limb lead is perfectly positioned to see this wave? Well, we kind of gave you the answer, didn't we? That's limb lead 1. Okay. You can sometimes look, not really for the 12 lead EKGs that are done, maybe in the lab, cardiophysiology lab with really fancy equipment, you can see biphasic, just like we talked a lot about biphasic, looking for the biphasic QRS complex. It's really harder to see in the P wave, so you need fancier equipment. So we're not going to worry about that. P pulmonale. So right atrial hypertrophy, we have talked about that. But that is called P. pulmonale. If you see P. pulmonale, it means right atrial hypertrophy. Okay, it's classically caused by pulmonary hypertension, has stretched out that right atria, because that means if you have pulmonary hypertension, that means there's a beaver dam somewhere in the lungs or in the left heart. It could be that far away. But you've stretched out and overworked your right atria, and now it's all wimpy. It's stretched out, and it's too big. That's P. pulmonale. Classic causes of P. pulmonale. I do like that question. I don't know if I can add more stars, but to give you hints, that's a high-yield question. P. pulmonale is caused by number one cause is left heart failure. Left heart would be the beaver dam backing blood up through the lungs and into the right heart, overworking the right heart. In that case, they'd have right ventricular hypertrophy as well. COPD, yep, that would do it. And an untreated atrial septal defect. So yeah, we talked about how that can just overload the right atria with blood, and it's always working too hard. And that'll wear it out over time. That can actually lead to pulmonary hypertension eventually. Some other causes, it could be a tricuspid stenosis or pulmonic valve stenosis. Those can both act as beaver dams, right? And yeah. Right. In these patients with right atrial hypertrophy, the axis of the mean electrical axis, the MEA of the atria, swings way to the right, past 90 degrees. So which way does the mean electrical axis for the ventricles swing in somebody with right ventricular hypertrophy? Also swings to the right. Therefore, the tallest P wave, remember we've talked before, tallest P wave usually appears in limb lead 2 or limb lead 1, but now it may appear in limb lead 2 or AVF or even limb lead 3. Limb lead 1 is usually the king. That's usually the best lead to look at to assess the P wave. In people with P. pulmonale, they will also have a broken 2.5 millimeter rule. So if you measure the length, the duration of the P wave, it'll be too long. If you measure the height of the P wave, it'll be too high. Right. And it might be, as we said, it could be associated with right ventricular hypertrophy, especially if they have a problem that affects the ventricle too. So left ventricular failure, pulmonic valve stenosis, not tricuspid valve stenosis. Would tricuspid valve stenosis cause a right ventricular hypertrophy? No, but maybe in the very long term it would after pulmonary hypertension occurred, but that'll immediately stretch out the right atria, so you get right atrial hypertrophy. Okay, look at this guy, 40-year-old male, longtime smoker, complaints of dyspnea. CT was taken of the heart. What do you make of that? Then you ordered an EKG. Well, here's the left ventricle. There's the ascending aorta. Here's the right ventricle. Actually, it looks like we have a little contrast going through that. There's the right atria. How's that look? That's ridiculously too big. Right? Where's the left atria, by the way? Remember, that's behind. It's behind the aorta, the ascending aorta. Can't see it in this slice. Yeah, it's crazy big. So this is P. pulmonale, or right atrial hypertrophy. If you look closely, you can actually see the problem in this patient. We got calcification in the tricuspid valve. So we got a sticky tricuspid valve. So every time atrial systole occurs, it can't empty its blood in it. And the new blood comes in and you get an overstretching all the time of the right atria. Okay, so we ordered the ECG. What do you make of that? Then my next question is, what about the the MEA of the ventricle. Where's that going? Well, one thing at a time. So let's look at the P waves. Looks like a pretty normal P wave. We got a biphasic though, don't we? So that's not normal. And limb lead 1 should always be positive. So we know the mean electrical axis of the ventricles is off. How about limb lead 2? Whoa, you never seen that one before. That's way too big, right? That's almost a full big, that's about 5 millimeter, or 5 little boxes, 5 millivolts. That's way too big, and it looks like it's too wide too. So this is obviously a patient with P pulmonale. How about that from last week's lesson, which I'm getting a little nervous about because not many people watched that very complicated lesson. And so you better, I don't think traditionally you don't understand how to find the mean electrical axis. You better go back and watch that. There's a lot of questions on the test on that. So what about the mean electrical axis? Well, let's just quickly draw our little circle. Okay, pick out our biphasic limb lead. Limb lead 1 we know is right here, so we'll draw a perpendicular to limb lead 1. Now which way is the current going? Well, we can look at the peeper, AVF. That'll tell us. If the peeper is negative, then the current's going away from it. If the waveform is positive, the current is heading toward it. So AVF, how's it look? Besides a huge P wave, it's definitely positive. So we know the current is going this way. So then we have to fine tune. So if you look at this, is the positive bigger than the negative, or is the negative waveform bigger than the positive? If the positive waveform is smaller, then we know the current is heading away from it. So the current's probably running about like this. So yeah, and we know the normal MEA of the ventricles is 0 to 90. So this patient has a right deviated mean electrical axis, which indicates right ventricular hypertrophy. If you have no clue what I just said, you better go back and watch that next lecture. Right? Everything I said. P wave is way too long. Patient has right ventricular hypertrophy as well. We talked about the MEA already. I just drew it for you, but yeah, there you go. There's the solution. Everything I just said. All right, so now let's kind of switch focus to the PR interval and the PR segment and learn about them. Okay, we remember the P wave, the PR segment is flat, and then sometimes we have a Q wave, sometimes we don't, depending on the camera view. A lot of times we don't have it because of the camera view. Also important to remember that, notice how all the QRS complex is built with 1, 2, 3, 4 straight lines. 4 straight lines. Inverted P wave. All right, so you're looking at an EKG, and all of a sudden you see this. Is that normal? No. It's supposed to be pointing up. So why in the world would the P wave be pointing down on limb lead 2? Yet the QRS complex is completely normal. There's nothing to do with repolarization. We know that's still depolarization of the P wave. Anybody know why? Well, limb lead 2, we can draw our axis, our little dial, our little circle. Limb lead 2 is right here. And we know that normally the current runs about that way, so it should be positive. But if it's backwards, the current has to be running through the atria away from it. That's the only way that can do that. And that's exactly the cause of this. So normally the SA node runs the heart, and there's limb lead 1 or limb lead 2, and it sees the mean, the MEA of the atria is heading right toward it. So it's got to be positive, right? But if it's negative, as we said, where's a picture of that darn thing? I thought I put one in here for you. But anyway, the current must be, the spark must be here, right? And then the wave would run backwards. right? So that's what happened. The spark was not in the SA node. So the wave of depolarization must be running backwards. Okay, remember, a current running away from a positive electrode causes a negative waveform. That's called retrograde conduction. So what would cause this retrograde conduction? Well, it's typically from a spark that is not sparking from the SA node. That spark, we don't call it a spark, we call it something else. It's called a ectopic focus. Or that's a mistake. That should be ectopic focus or ectopia. You could also say the patient has ectopia. Let me clean that one up. 394. Fix. Okay, so it's an ectopic focus. That's just a wild, rebel, automatic focus. For whatever the reason, it's beat the SA node to the punch. And for at least that beat of the heart, this ectopic focus was the shiny star. It ran the heart, right? It may continue to run the heart for a lifetime if the SA node is broken. Or it just may continue to come out after you go out on a hard night of drinking. Alcohol makes the heart very twitchy. These are common after heavy alcohol drinking. All right? So that is the story. Ectopic foci is the buzzword. Where do retrograde running ectopic foci usually occur? So where do these things come from? Where can these wild ectopic foci arise? So the left atria, the myocardia of the left atria, if it does, it's called a premature atrial contraction. We'll look at all the AKs for that. It could arise in somewhere called the junctional region. If it does, that's called a premature junctional contraction or complex. We'll look at the difference between those. And occasionally it could occur in the ventricle myocardium near the bundle branches or bundle of His, because it's possible to run a current backwards without any delay through the AV node. And so it's possible, not unlikely. I mean, usually it's a PAC or a PJC are the causes of these upside down P waves. Oh, here's the picture. Okay, so here we have a current. Just a little cartoon. So here we have different ectopic foci, little wild rebels. They've beat the SA node, got beat to the punch. And the current is definitely running away from the cameras. Therefore, it's going to draw it upside down like that. Okay. Same in this junctional region. This one occurred in the bundle of His, and we'll look at that junctional region. What are these ectopic foci called? Atrial premature complexes, or PACs, premature atrial complexes or contractions. I mean, really, the ectopic foci is the electrical abnormality which occurs, and that can give rise to EKG findings called atrial premature complexes. Right? Those are really visible on EKG. The best thing to call these always is the ectopic foci. Right? But ectopic foci cause premature complexes or premature contractions. Right? If they're in the junctional region, those are junctional premature complexes. Or you could say a junctional ectopic foci as well. Ventricular premature complex or PVCs. These are the buzzwords, right, that you see on the internet and around. PACs, PJCs. It's another typo. Just amazes me how I prep and I don't see it, but when I lecture to you, there it is. I think it's really got to do with this because I never use this in class. I don't have this option, so this is very cool that I have this. All right, then PVCs, of course, those are premature ventricular complexes, and they're rebels. They've beaten, but they don't have to be rebels. They might be a hero too, as we'll see. But whatever the reason, they've beaten the SA node. They've taken the job of pacing the heart, at least for that beat. We should talk about an arrhythmia. So all ectopic foci result in abnormal EKG. If you have an abnormal EKG, you have a heart arrhythmia. Let me say that again. If your EKG is abnormal, you have a heart arrhythmia. So all of these ectopic foci, PACs, PJCs, PVCs, these are all arrhythmias. Whether they're there all the time, sometimes they're there all the time, sometimes they're not. Okay? That means the heart's rhythm is a little off. There's just another one. This one's coming from the AV node. So this beat the SA node to the punch, and yeah, it's running the heart now. And we see the current mainly running away from it. So the P wave is drawn downward. What do they do? What do these ectopic foci do? Well, they create weird, another buzzword, non-sinus. So this arrhythmia, this is a non-sinus arrhythmia. That's another one I could have added in there. Non-sinus arrhythmia means the SA node is not responsible for this. You can have sinus arrhythmias, which I'm not going to get into, where the SA node itself is beating erratically and causing an abnormal EKG. So that's still an arrhythmia, but that would be a sinus arrhythmia. Most of the ones, all the ones I'm going to talk about are non-sinus arrhythmias. Right? So ectopic beats, we said already. What are they? The premature beats or extra beats. They can sometimes take over the heart and run it very fast, more than 100 beats per minute. That would be called the supraventricular tachycardia, or SVT, supraventricular tachycardia. Here's my completely politically incorrect cartoon, but here's an example. Here's the SA node. He's the pilot of the ship, of our heart, if our heart is a ship. And normally he runs the show, but here's some terrorists who have taken over the airplane. And this one's an AV junctional pacemaker, so here's a PJC and here's a PAC. And if they run the heart all the time, the SA node is helpless. So they can take over. Okay, so that's kind of the politically incorrect cartoon. Here's another term we need to discuss, palpitations. You've heard that before, right? Grandma's got palpitations again. She's not feeling good today. What does that mean? Any arrhythmia of the heart that a patient can physically sense, that's a palpitation. If a patient comes in and say, "Doc, my heart is racing," and you listen to her heart and it's going 150 beats per minute, even though that's a tachycardia, it's still called palpitations because she can feel the abnormal rhythm. Most of the time, though, it's used for these PACs or PJCs or PVCs, and the patient will come and say, "God, my heart, I can't sleep last night. It's flipping up and down. It's jumping. My throat is twitching." Those are still palpitations, although those aren't. You listen to the heart and the rhythm's 80 beats per minute. Those wouldn't be a supraventricular or wouldn't be a tachycardia. But bottom line, anytime the patient becomes aware that their heart is doing something funny, they're diagnosed with palpitations. Good? What about palpitations? So usually they're no big deal. In fact, we'll look at a study here in a minute. Super, super common in people. Every one of you listening to this has probably felt your heart skip a beat at one time. That's a palpitation. But usually they don't bother you. Now, some people just can't, for whatever reason, just like some people can't feel back pain. Some people can't feel these palpitations either, and we don't know what the deal is. It's probably they just don't have good sensory output from that organ. I had a patient, I digress a minute, but you guys know what a Schmorl's node is? Did I have you for, if I had you for spinal anatomy, you do. So there's the vertebrae, right? Spinous process from the side view, right? So Schmorl's node occurs, it's an intradiscal herniation, and they're almost always asymptomatic. The rule is 10 millimeters. If it gets bigger than 10 millimeters It can be trouble. And I've had clients had to have surgery, fusion, tough fusion, because they have to scrape it out, become symptomatic. I just had a patient this weekend with one of these things. Well, that might be a little bit too much, but it was more than 66%. It was 14 millimeters. It was huge. I thought for sure, when I made sure the CT scan was good enough to talk to her about, I thought for sure her complaint was going to be low back pain, but it wasn't. She didn't have any low back pain, yet she had this thing. Why? Maybe she just, same reason here with palpitations. She just doesn't have the wiring going to the brain to tell her the thing hurts. That's all I can think of. But yeah, the back pain, you'll scratch your head when you start matching back pain to imaging findings. Anyway, I digress, and I don't want to do that. I want to get done with this stuff. I don't want to make these videos too long. All right, so yeah, palpitations, they're usually benign, but they can become problematic, especially if they have a high burden of these things, especially PVCs. I mean, PVCs will decrease the blood output of your heart. The stroke volume decreases, so they can be problems. So they need to get checked by a cardiologist once you discover these things. And the patients, of course, can become quite anxious because of these things. All right, now I mentioned the junctional region, and some of you are going, what the junctional region? What is that? Junctional region. So let's talk about the AV junction, otherwise known as the junctional region. Where the heck is this thing? And it's a very common place for ectopia to occur. I can use that word ectopia again. Matter of fact, let me write that ectopia. Don't think I stressed the importance of that word. It's a very important place where ectopia can occur, or a very common place for an ectopic foci to occur, same as saying ectopia. But the authors have a hard time agreeing on where the heck this is, so we'll go with Chou is the most evidence-based book I have. Really good book, but it's really deep. Chou says, quote, it extends from the AV node approach tracks to the end of the bundle of His. So in other words, he's talking about the AV node approach tracks, the AV node itself, and the bundle of His. So other authors have confirmed this, including Garcia. So this is the best way. Some other authors, so here it is. This is the junctional region. Okay? But some other authors have included, you can get ectopic foci or ectopia arising from the pulmonary trunk, for example, and they include that in the junctional region, which they really shouldn't, because it does present with a different type of waveform. It's hard for these ectopic foci in the pulmonary trunk. It's hard for them to invert the P wave. So we'll go with the main authors, and so these are the approach tracks, whether there be one or two. Some people have a fast and a slow. I drew two here. I think it's 25% of people have double approach track. Then the AV node, penetrating fibers, and there's the bundle of His. We'll see how these are broken down in a second. So junctional region contains so it's not surprising, right? The junctional region is a very common place for ectopia to occur. It does have the second and the third string fastest depolarizers, although the SA node is certainly the Usain Bolt, the quicker than anybody else. Right behind it is the AV node, and right behind that is the bundle of His. So if anything goes wrong with the SA node, I mean, these things might not be a hijacker type person. They may be a hero. They may be saving the heart and running the heart normally. Heroes or zeros? Well, they can. Google says that's a mischievous. That kid does look mischievous, if you ask me, especially that face. Maybe he's not in real life, but he looks mischievous to me. They can be mischievous. They can be heroes or zeros. So sometimes these fast depolarizing cells, they can beat the SA node to the punch when there's nothing wrong with the SA node, and they can take over. So there's two types of mischievousness. There's there's this dude, we'll call him, what will they call him? Joe. there's Joe, who is erratic. He just randomly pops up and runs the heart for a couple beats or a couple hours, and he, not every beat either, maybe 3 beats, he runs the heart, and maybe the SA node wins the battle in the next couple beats. So it's random, and it's erratic pacing of the heart. Or you can be mischievous, and maybe Joe just goes full blast and paces the heart at a pace the SA node can't handle. Maybe he'll run the heart at 120 beats per minute. The SA node is set at about 80 beats per minute. So the SA node will never have a chance. So you can get a supraventricular tachycardia like this as well, which would be called a junctional supraventricular tachycardia. Okay, and this is, I kind of talked about this, but this is focal beats complexes. What's the deal with this? If the mischievous ectopic foci occur anywhere in the junction region, they're called junctional ectopic foci. Abnormal heartbeats that result from ectopic foci are called premature junctional beats. And that's where the PACs and PJCs and PJ premature junctional beats is PJBs, premature junctional complexes. So that's where that kind of a play on words. The EKG phenomenon is called premature junctional complex. The physiological phenomenon that causes the premature beats or the premature junctional complexes, the physiological phenomenon is called an ectopic foci or a junctional ectopic foci. Okay, that's just kind of a play on words there. So the mischievous AV junction. So these ectopic foci are found within the AV node or its approach tracks. Usually, they could be anywhere in the junctional region, though. And again, sometimes the SA node is a hero. Oh, that's another error. Wow, I've done this so many quarters, and I just catching stuff. I must be more awake. So sometimes the AV node is a hero, right? If the SA node fails, like say you've had a myocardial infarction or you had an infection and you knocked it out, then the SA node won't work. The AV node will come to the rescue and it'll rescue the heart. Maybe the SA node is sputtering. It's like having a bad day, and sometimes it generates an action potential every 80 beats per minute, and sometimes it just doesn't. And so there's 2 possibilities with the AV node saving the heart. And these are called junctional escape beats. They're not mischievous, they're heroes. They are saving the heart because the SA node failed to beat. So somebody's got to pick up the slack. And it's usually the second string kind of fast runner, and that's usually the AV node. So if there's 3 or less, it's called a junctional escape beat. But if there's more than 3, 4, 5, 6, 7, 8, 9, 2 hours worth of them, I mean, they're still junctional escape beats, but we call it the patient is in a junctional escape rhythm. The SA node is out, and they may permanently be in a junctional escape rhythm. Okay, what is the cause? What would cause the SA node to fail? And I took a lot of these slides out because we never have enough time in this class. Sinoatrial node block. Remember, the SA node is the sinoatrial node. So one of the most common causes is a block, where there's 2 types of SA node block that can occur. One, the physiological mechanism that generates an action potential, something's messed up with that, and the SA node just can't make an impulse. So that would lead to SA node failure. Another one is the capsule around the SA node has become non-conductive. Maybe it's scarred up from a heart attack or an infection. But for whatever the reason, the SA node makes the impulse on time, but it can't get out of the capsule around the SA node. So both of these conditions, there's no signal coming out of the SA node. Typical reasons include a myocardial infarction, an infection that have both taken out or attacked the SA node. Digitalis toxicity is also a common cause of SA node dysfunction, where grandma and grandpa forget whether or not they took their digitalis in the morning. Always get grandma and grandpa a pill case, because some of these medications can really mess them up. And they thought they couldn't remember if they took their digitalis, and they thought, well, I better take it again just in case. And they start doing that repeatedly. You can become toxic. Cause the heart to become twitchy and crazy. All right, let's look at one here. It's a 38-year-old in for a pre-employment physical. You do a EKG. You look at the rhythm tracing, and what do you think? So these three dots, when you see these on the test or anywhere, that means this exact same pattern goes on and on and on. All right, should introduce the RR interval. One of the first things I do on an EKG is I look at the RR interval, and it should be steady. If whether it be the SA node or somebody else is evenly depolarizing and pacing the heart, this RR interval will be in sync. I mean, we could count this. It's this length is the same as this length. That's the same as this length, right? People with palpitations have a messed up RR interval, because usually like a premature atrial complex, you might see something like this way ahead of schedule. And so the R wave would be here. So if they have a disrupted RR interval, think palpitation, or think premature complex somewhere. Think an ectopic foci somewhere. But that's not the case here. This guy is going pretty smoothly. What do you think of this? Well, it's a little slow, right? And we'll just really quickly, and you should, if you don't know this rule, you need to know it. So every big box, like if the next R wave was here, that would be a heart rate of 300 beats per minute. If it was here, 150. If it was here, 100. If it was here, 75. If it was here, 60. If it was here, 50. So anything under 60 is a bradycardia. So we do have a slight bradycardia going on here. And where's the P wave is the next question. It's there. Dr. Gillard, what do you mean it's there? I don't see it. Let me tell you what's upside down. It's actually right here. So the problem is there's no PR segment, right? So this is a classic PJC. It's premature, it's ectopic foci somewhere in the junctional region. Specifically, it's in the proximal AV node. I can tell you where it is. Right? So everything I just kind of said, there's the P wave, but it's inverted. There's no PR segment, right? PR segment is absent. And yeah, so because there's three or more of these, this is called a junctional escape rhythm. Junctional escape rhythm. The patient had a heart attack or something. His SA node is broken. It's not doing anything. Right? Make sure you know this. Like I just did, you should have this memorized, because I might ask you questions on the test, and you're not. Well, I guess you can use anything you want now, can't you? Because I can't keep my eyeballs on you while you take the test, but you need to know that. You get on boards, you're not going to have anything in there with you, so this better be in your noodle. So spend some time and memorize that. Doesn't get, once you get down to below 50, this rule isn't super accurate for the low numbers, but right up in here, this region to 50, it's pretty accurate. Okay, what about the EKG findings? Kind of just saw that, didn't we? But the P wave will always be inverted in people with junctional ectopia or ectopic foci that are arising somewhere in the junctional region. It'll always be inverted. Got it? All right. Why? Because the rebel current we know why already, because it's running away from limb lead 1 and 1. The limb leads, the 1 and 2, and even the peeper, AVF, running away from those things. Another rule, PR, the PR segment will always be absent, right? Or it'll be stubby. It'll be super short. So you should have a nice fat PR segment, that flat line, right? The other thing we need to learn, the P wave may be before, it may be hidden by, or maybe after the QRS complex, right? So here's a ectopic foci that arose in the, it looks like the proximal half, kind of in the middle, but we'll call it the proximal half of the AV node. And so that's the pattern that you get, right? So there is no, the signal occurs here, so there's no delay of the signal getting through. Part of the signal immediately goes through the AV node, so there's no delay. So you have no PR segment, right? So that's a classic PJC right there. And you can see the inverted wave. You can see the very short PR segment, and yeah, that's what that is. Where does it occur? So there's 3 places. So you can, and we can tell on EKG where it occurred. The AV approach tracks, or the proximal AV node, that would give us an inverted P wave, which is visible before the QRS complex. Okay, so if it occurs in the approach tracks or the proximal AV node, which we just looked at an example of that, it's going to occur right before the QRS complex. If it occurs in the distal part of the AV node, you're not going to see it anywhere. It's going to be hidden by the QR complex. If it occurs even later in the cycle, the cardiac cycle, if it occurs in the bundle of His, you'll see it, but it'll be after the QRS complex. Got it? After the QRS complex. Right? And here's the examples. There's one that occurred clearly before the QRS complex, and it's in the green area. It could occur anywhere in this region, right? Approach tracks or in the proximal AV node. Here's one that you can't see. This is hidden. That means it's occurred in the distal AV node. I got to fix this drawing a little bit. And if it occurs after the QRS complex, notice they're all inverted. That means it's occurred in the bundle of His itself. Got it? Okay, let's check out this. 18-year-old female comes in. She goes, Doc, she has neck pain patient. Doc, I got these weird movements in my chest. She's a little worried about them. She has some anxiety, obviously. So you run an EKG. What do you think? Well, first thing we got to do is look at that RR interval. Just by eyeballing it, it looks pretty steady. But then we need to look at the speed of the heart by using those same R waves. Let's see if we can find one on a main line here. Well, yeah, they're all about the same. Let's use this one. So it's 2 in front of this big line here. So this would be 300. Is her heart going 300 beats per minute? No. Okay, let's do another one. Is it going 150 beats per minute? No, there's no R wave there. Let's do another one. Is it going 100 beats per minute? It's going almost exactly 100 beats per minute. So it's kind of borderline. This could easily be from the anxiety, though. This probably doesn't mean it's a tachycardia if someone's heart is running even 105 beats per minute. But when we look at the EKG, this is more than anxiety. How can I tell that? Good, some of you got it. Where is the P wave? It's upside down. And where's the PR segment? It's non-existent. All right, so this is a junctional. I mean, technically it's 100, at least 100. So it's a junctional tachycardia going on here. So somebody, and we can be even more specific, where is the ectopic focus occurring? Well, because it comes before the QRS complex, it is coming in the proximal part of the AV node or the AV node approach tracks. Got it? Is the patient in sinus rhythm? No way, right? The SA node is not running. The SA node is knocked out of action. This is an arrhythmia. It's technically a supraventricular tachycardia. Okay, everything I just said. All right. Once again, if the junctional ectopic foci runs over 100 beats per minute, it's a junctional tachycardia. Specifically, it's a junctional supraventricular tachycardia because the tachycardia is not coming. We haven't even talked about PVCs. I don't think we'll get to PVCs as we missed a lecture because of the holiday. But yeah, so it's a junctional tachycardia, which is a member of a bunch of tachycardias. It's a member of the supraventricular tachycardia family. Before we go any further with these tachycardias, let's look at the PR segment, PR interval, make it more official. So, interestingly, Guyton actually calls this the PQ interval. No electrophysiology book, cardiac physiology book would do that, but Guyton does, and he's got a good reason to do it, because where is the PR interval? It starts at the beginning of the P wave, and it runs to the beginning of the QRS complex, which is Q. So why not PQ interval, right? So Guyton's got a good point. The problem is, on EKG, you don't usually see the Q wave. So it gets confusing for students. It usually starts at the R wave, so hence the PR interval became more popular. Okay. So the PR interval includes the P wave and the PR segment, right? Do I need to draw the PR segment? We've already really talked about it. It's the PR segment. Why PR interval and not the PQ interval? Again, Guyton says it's called PR interval because the Q wave is usually not on EKG. All right. Definition is the time it takes, definition of the PR interval is the time it takes for the wave of depolarization, the action potential, the current, whatever you want to say, to travel through the atrial myocardium, to spread across the atrium, and to go through, completely through the AV node, including its delay, and even get into the bundle branches and Purkinje fibers. It doesn't, once the current gets into the ventricular myocardia, that needle jumps. And then that's the start of the QRS complex. So a lot of people, physiology tests, they'll screw that up and they'll think, well, it's the time for it to get through the atrial myocardia and that's it. But no, the signal goes through the AV node and the bundle of His and even Purkinje fibers, and nothing happens. But once it hits the myocardium of the ventricles, Purkinje fibers dump into the myocardium of the ventricles. That's when the line ticks down for the Q wave. What is normal? So we have another rule to remember, the 3x5 rule. So its duration is normally between, like a 3x5 note card, 3 to 5 millimeters. Or 3 millimeters is the same as 12 seconds, 0.12 to 0.20 seconds. Should use limb lead 2 for this assessment, by the way. And yeah, so 0.20 is the same as one big box. So it's normal for it to be about one big box, and it shouldn't be less than 3 little boxes. But don't forget, because a lot of times these PR intervals are right exactly at 3 millimeters. So another rule is, for a normal PR interval, you have to have a visible PR segment. If you don't, it's a screwed up PR interval, even if it's 3 seconds. So it has to not only be in these time zones, these time restrictions have to apply, but it's got to have a visible PR segment. Got it? Let's do another one. Does this patient have a normal PR interval? Let you look at that while I hit some water here. Is it? Well, 3x5 rule. First of all, does he have a PR segment? Yeah, it's got a PR segment. It's about as long as the PR, the hump here. So that's cool. So it looks like it starts right about here. And 3x5. So it's shouldn't be shorter than 3 little boxes, or 0.12 seconds. So there's 1, there's 2, and there's 3 would be here. Yep, so it's looks to be exactly, or maybe just about exactly 3 millimeters, or 3 little boxes. So yeah, that's normal. Yeah, it's pure, it's normal. Okay, everything I just said. How about this one? Here's a 48-year-old who passed out after a basketball game. Come to find out, with watching his son play, and was in what's called AVRT, was in a supraventricular tachycardia, went to the emergency room, but now he's not in tachycardia, or is he? You tell me. Well, let's see what we got. I could put 3 dots here too, because this just goes on and on forever. It's one of the pre-existing conditions for AVRT, as we'll learn. So immediately you can say something's messed up. You don't have to measure anything. Where's the PR segment? There is none. This is not a normal PR interval because there's no PR segment. And then it breaks another rule. Remember, the QRS complex is built with straight edges. Is that a straight edge? No. This is okay. That's okay, but that's not. This is called a delta wave, seen in people with Wolff-Parkinson-White syndrome. People with Wolff-Parkinson-White syndrome, their nemesis is going into atronodal reentry tachycardia at AVRT, or not nodal, sorry, AVRT, atrioventricular reentrant tachycardia, not to be confused with atrial nodal or atrioventricular nodal reentrant tachycardia. We'll get to that stuff. Yeah, everything I said. Shorten PR interval. Ooh, I like this slide, lots of stars. What can shorten? I can see the question, can't you? All of the following can shorten the PR interval except blank. Well, junctional tachycardia is definitely shorten the PR interval because, I mean, you're in the junctional region. The spark is, the ectopic focus is in the junctional region. So you basically bypass the slowdown portion of the AV node. Right atrial ectopia, so ectopic focus in the right atria. Especially if it's fairly close to the AV node, the P wave will be upright, but it'll still be way too short. We'll talk about, next time we'll talk about PACs. Hole in the fibrous skeleton can do it. Yeah, Wolff-Parkinson-White syndrome. You can pre-excite the ventricles by a hole in the fibrous skeleton that's not supposed to be there. We'll talk about that one. Bypass Langerhans-Levin syndrome is a patient that has fibers that skirt, as James fibers, they're even called. They skirt the AV node and can let the electrical signal kind of sneak around the AV node, and therefore the ventricles would depolarize too quick, and there goes your PR segment. And a damaged AV node that doesn't slow down the current, that's really dangerous. If you ever get a supraventricular tachycardia with a damaged AV node, SOL, you could die from that quite easily. Here's a 65-year-old male and he has neck pain, dyspnea, exertion, malaise. What's malaise? Not malaise-ma. We'll learn malaise-ma, the mask of pregnancy. We'll learn that in dermatology. Malaise is they don't feel good. You have malaise when you get sick and don't feel good. He also has got diabetes. There's a past history from mild myocardial infarction 3 years ago. Doc said no big deal on that. His memory's not the greatest. So what do you think? Well, let's go through, check the heart rate. RR intervals, the dots mean this continues for on and on. I'll tell you that the RR intervals are the same. Yeah, this is what we've been talking about. We have an upside down and peaked. We won't get into peaking, but we have an upside down QRS P wave. How about the PR segment? It's there a smidgen, but that's not long enough. So PR interval is messed up. And what is the heart rate on this guy? So we'd start it right here at this box. 300, 150, 100, 75, 60, 50, 43, 37. I mean, it's slow. It's under 40. It doesn't get as accurate when you get down. You'd have to count all the little boxes, but it's slow. So yeah, what do you think happened? Anybody know what happened? And that's abnormal, right? PR segment. Even though, I mean, technically the duration is 1, 2, 3. The duration is okay, but the PR, there's no PR segment. So the PR interval is messed up. Yeah. So the patient has bradycardia. That's less than 40 beats per minute. Our intervals are steady, so it's probably not a mischievous ectopic foci. The obvious, I didn't even say the obvious, it's upside down. We have an inverted P wave. So yeah. So anybody figure out what happened? Yeah, the patient, it was the myocardial infarction. It damaged the SA node, and they had that kind of a delayed reaction in it, or maybe they missed it at the hospital. But yeah, they have a junctional rhythm all the time because the SA node was damaged. So they're always in junctional rhythm. And this time the AV node is not mischievous at all. It's just saving this guy. It's pacing the node, or pacing the heart. And we can tell you it's coming from the proximal AV node because it's before the QRS complex. Got it? I wanted to add something here on slide 441. I need to add inverted P wave. I forgot to list the obvious there. Bradycardia. So that's under 60 beats per minute. But and I know that's all the books use 60 beats per minute. That's bradycardia. There's many of you listening to this who are in bradycardia right now. But many well-trained athletes are really fit individuals, maybe just young people who aren't even fit. Their hearts run down into the low 50s or even the 40s. Elite athletes may be down to 32. And they typically, when your heart goes that slow, you're in that great a shape, you typically have some ectopic beats from the junctional region because that's the natural trigger is down that low. So some athletes have problems with that, have palpitations, and they get anxiety from that. And there's really nothing wrong. Their heart is just in such good shape. But when is sinus bradycardia? What's sinus mean, by the way? Sinus means sinus rhythm is causing that. And it could be any type of bradycardia. I mean, sinus, I probably just should have said bradycardia, but sinus means the SA node is running the heart. But when does the problems occur? It's all up to the patient. When the patient becomes symptomatic, then the bradycardia is a problem. What are the symptoms? Again, malaise, low energy, pre-syncope. They're not getting enough oxygen pumped out of their heart. They could get lightheaded. They might look a little pyloric or cyanotic. And what are some of the pathological causes of sinus bradycardia? So increased intracranial pressure. I won't get into the mechanism, but obstructive jaundice, myxedema, beta blockers overload. Those are classic causes of sinus bradycardia. Remember, sinus means the SA node has just not been damaged, because there's plenty of causes of non-sinus bradycardia. Myocardial infarction. I could have even added that to that slide, right? Maybe in the future. What about non-sinus bradycardia? All right. The 1500 little box rule, you should probably know about that if you don't already. If you want to precisely, maybe I'll use this because you all have your iPhones out and probably texting each other while you're taking this test. But you count the number of little small boxes, and it's 1,500 divided by the small number of boxes, and it works pretty good. Let's try it. So what's this Is that the same one? I think the same one we were looking at before. Now let's do it. So that's 5 little boxes, 10. Remember, one big box is 5 little boxes. So it's 5, 10, 15, 20, 25, 30, 35, 40, 45 plus 1 is 46. And 47, I don't know how I counted that. Did I mess up? 5, 10, 15, 20, 25, 30, 35, 40, 45. No, I messed up down there. It looks like just 1. So it looks like, because it started 1 late, so that would be 46. Maybe it would be 47. So I'll give it 47. Could probably get rid of that. But anyway, it's low, right? It's 31.6 beats per minute. It's under 40, as I said before. Let's do another one. These are fun, aren't they? So I didn't have the full tracing, but the same rhythm goes on and on and on. And I'll give you the heart rate is 35 beats per minute. So 72-year-old, he suffered a myocardial infarction 6 weeks ago. He has neck and back pain from the hospital stay and laying around. So he's in for treatment. You think, I better run an EKG just to make sure. You run an EKG, and this is what you see. And this pattern goes on and on and on. What do you think? Well, we don't have to calculate the heart rate. He's in bradycardia. Is it sinus bradycardia? No. Where's the P wave? It's not a sinus rhythm. This is an arrhythmia. So he's in non-sinus bradycardia, if you will. And where's the P wave? It's not here. It's actually right here. So for whatever reason, it doesn't usually happen, but who's running the show? Oh, I know the junctional region. I know this is a junctional arrhythmia. In fact, it's a junctional what? It's saving him. It's the hero. It's running the heart. This is a junctional escape rhythm. This is coming from the bundle of His, right? The bundle of His causes a very late inverted P wave. Got it? Everything I just said. And we will call it a day. All right, we'll see you on Thursday.